I'm Herb Schneider. I've been interested in prostate cancer throughout my entire career. The changes we are now witnessing, I think, are going to make a huge difference in management of this disease. These are lesions in the prostate. And in times prior to this current level of discussion we're having, we basically biopsied the organ. Our logic was if we had enough samples from that prostate, we would learn what's going on. The reality is there's much more to that story. What we really want to do is what we call targeted biopsies. With multiparametric MRI, we can literally see what we're looking for, and then we can sample it. The MRI is very sensitive to certain size abnormalities, and those abnormalities usually are larger because something's going on inside them. The small areas of the prostate that have been and probably will continue to be diagnosed as prostate cancer until we do image-guided biopsies don't have the same growth characteristics that the larger lesions do. The index lesion has certain characteristics. It doesn't stop its growth process. In life, in general, there are certain cell cycles to organs, and cells come into that organ and they leave that organ. That is essentially death of the cell. The index lesion has characteristics that resist this process. Dr. Liu, who was at Johns Hopkins, did a study, and he dealt with men who had metastatic disease and unfortunately passed from their disease. At the time of the passing of the gentleman, was able to analyze the tissue in these areas which are essentially metastatic or spread of disease. And then he looked very carefully at the prostate. And what he found was the larger lesion in the prostate that would be seen by the MRI, in fact, had the growth characteristics that I'm talking about. So they then did genomic studies, and they were able to link this level of disease to this as its origin. Here is an MRI. This is an ADC map. Point is, there's something going on here that's very different. It doesn't look like it should be there. But we literally can see the bad spot in the prostate without opening it up. We can do it with technology. So we can identify significant prostate cancer within a prostate that we're drawn to analyze, for instance, with an elevated PSA. With selective therapies, we have the potential to focus in on the problem and not disturb the rest of the prostate. We're minimizing or eliminating the diagnosis of insignificant cancer, finding the significant before we eliminate it. John George is a gentleman that I met as I was pursuing high-intensity focused ultrasound. He has done 400 high-intensity focused ultrasound or HIFU procedures. He was very much involved in fusing MRI and ultrasound so we can use it to benefit you, the patient. And he did the first HIFU procedure that has been done in the United States since approved by the FDA.
I found out in coming through my practice in an era where the radical prostatectomy was sort of a, if you will, a knee-jerk reaction. We find prostate cancer, we feel that in a way we're fortunate that we found it early, so let's get that patient into the operating room as quickly as we can and perform radical prostatectomy. And I think my experience as a surgeon, I felt that in a great number of cases that perhaps the patient had been overtreated, that maybe the treatment that we'd rendered with surgery, while it had cured their cancer, and the patients were coming back being told that they were cured of their prostate cancer, but sometimes they weren't that happy with that news. They would say, well, you know, I have this leakage, and you know, I've lost my sexual functioning. You know, I was a little bit frustrated for them, coming at it from an empathy. So I heard about HIFU therapy, and to be honest, I was very skeptical. And the first time that I saw the procedure, the technology, I was just so impressed with some things about it. The main thing was that it was just so precise. Started in Indianapolis many years ago. It was refined. A lot of the early work was done in Japan. The folks in Japan have a fear of radiation, and they were interested in this option, and a great number of cases were done over there. And then we have some wonderful colleagues in Britain who have done so much of the research, and now the data is maturing, so we can comfortably say to patients, this is not experimental. The community in Columbus is really very blessed to have Dr. Sweeney and Dr. Riemenschneider here, because I've worked with them on a great number of HIFU procedures, and they are just so engaged and so eager that I think for the community here in Ohio and surrounding areas, it's just a real blessing to have them here. I firmly believe that patients who are suspected of prostate cancer or who have been treated, they're concerned about having a recurrent prostate cancer. A great number of patients in our country have been treated with radiation therapy. There's a 25-30% failure rate over 10 years with these patients, and we have a role of HIFU therapy in that group of patients. But what do we have with HIFU? Well, we have the ability to target. We can use the information that we've gained from fusion biopsy. We can incorporate that into the HIFU system, so we can target the area that needs treating very precisely. You can very close to eliminate urinary incontinence, and you can also, in most cases, provide the same degree of erectile functioning that the patient had prior to HIFU after the HIFU therapy. With HIFU, we have a system where we can get feedback immediately that the targeted tissue has been destroyed and that the healthy tissue or the nerve endings and the blood vessels have not been affected by the energy that we've put in. And you really can't do that with any other prostate cancer therapy. Visual panel, keyboard, a system that allows us to keep the surrounding tissues cool because we're producing a very intense thermal reaction. That's how HIFU works. Ultrasound waves that come through the tissue and reach what's known as a focal point, which is a very small area that is precise, and that tissue is ablated or destroyed. This is a depiction of how precise the energy is. If you can imagine when you were a child maybe having a magnifying glass and the sun rays coming through that magnifying glass, the energy from that light converging down on a piece of paper, you could actually burn a hole in it. This is the intensity of HIFU energy delivery. We term it an acoustical scalpel. You can use it a second time. Once you've had the radiation therapy to your prostate, you really can't put more radiation into the area again. So we have this option of using HIFU therapy in that scenario. We don't have any blood loss. It doesn't use radioactive energy. The procedure is done on an outpatient basis under an anesthetic. The recovery time is generally very quick. Patients wake up from the procedure, leave the outpatient surgery center. We use a Gleason grading system, and I will simply say that the cancers that we commonly see are graded from a 6 number to a 10 number. The 6 being a cancer that's less aggressive, and a Gleason 10 lesion being a much more aggressive cancer. We treat the prostate in zones: the top of the gland, the middle of the gland, and the part of the gland that's closest to the rectum. The current wave in prostate cancer therapy, whether it's primary treatment or treatment of a patient that has had radiation therapy, is to define their cancer as precisely as you can with MRI and with targeted biopsy, and know what's going on in their prostate that poses a threat to them. Then you can use the HIFU energy to treat the areas in the prostate that are of concern.
I want to give you a brief summary of what we have told you in this video. There is significant interest in non-invasive partial gland treatment for prostate cancer. This requires advanced MRI diagnostic study. The index cancer is visible by MRI and is the significant cancer. The other areas of prostate cancer, if present, are considered insignificant. Pretreatment MRI, two separate configurations, demonstrate the presence of the index lesion. Here we see MRI fused with ultrasound, which allows us to do targeted biopsy, meaning we can go directly to the trouble spot in the prostate and sample it. And we can use this same fusion system with our HIFU to focus the HIFU energy for treatment. And here is that occurring. This is the HIFU energy being focused in an area of the prostate. And we can see the tissue changes that confirm destruction of the problem area. MRI 6 months after treatment shows no evidence of disease, only the scar from the prior treatment. The PSA is at a very low level, almost undetectable. Repeat biopsy is negative, and the sexual function score is normal. Other areas that may contain insignificant cancer are surveyed at intervals just like patients treated with lumpectomy for breast cancer. Focal HIFU has been used in England for over a decade. A study done at the University College London has reported on 625 men with intermediate or high grade and small volume or moderate volume prostate cancer. These patients have been followed for 5 years or longer, and 97% are disease-free. The overall survival is 99%. Here are graphs that demonstrate that success in treatment. Additionally, the continence rate is 98%, and sexual erectile function is 86%, both of these at 3 years of follow-up. George Kreil of the Cleveland Clinic in 1973 made a change from radical mastectomy, which was whole gland therapy, to lumpectomy, which is focal therapy, which is now the standard of care for most breast cancer. We believe that HIFU, like lumpectomy, will become the standard of care for early diagnosed prostate cancer. Focal HIFU is done as an outpatient, is associated with rapid recovery and low risk of complication. Usually the patient returns to work in less than a week. An animation of HIFU follows and shows this precise, non-invasive treatment for prostate cancer. Following the animation is a poster for your review and study.